Guys, welcome to week 10. So we're going to start out this week with the chapter that we did not get to last week, 39. And then weeks 5 through 10, you're going to have a test on. You should be getting that information regarding proctoring soon. So good luck on that. Please email me with any questions that you might have. Okay, we're going to start out with chapter 39. Also, I posted or I will post, it'll be by the end of the day, PowerPoint on some major concepts for the test and topics from your syllabus and a few suggestions. So make sure that you look at that in the PowerPoint section um, of your file, of the files. Okay. All right, so chapter 39 involves pediatric intervention and skills. So generally, this wouldn't be a section, most of it wouldn't be lectured on. Because it's really a skills assessment. So, but I'm gonna go through the major concepts. There's some of it that can be lectured on, it's the consent, things like that. So I'm gonna share my screen for chapter 39 PowerPoint. Also, it's a good idea sometimes to print out the PowerPoint, and as I go along and add to them and things like that, you can add to your PowerPoint, so your notes will be more comprehensive. Okay, the first major concept in chapter 39 is informed consent. Informed consent, we talked about it with adults, but informed consent for children is a little bit different because we're supposed to be capable of giving consent, and usually it's at the age of 18. However, there are some special circumstances if you have emancipated minors um, and certain medical testing like birth control, things like that, that are a little wonky for this age. So we'll go through that in a minute. The person must receive information that's needed to make an intelligent decision. So usually the parent, if the child is under age 18, they have to receive information to make an intelligent decision. All the negatives and the positives, the risks and the benefits. The person must act voluntarily in exercising freedom of choice, so they can't be coerced. They have the right to accept or refuse any health care. So that gets wonky when you have, if a parent refuses a medical treatment that will save a child's life and they're refusing, like for Jehovah Witness not receiving blood products, that kind of thing. Sometimes that goes to an ethics board at the hospital at that point. So it's not sufficient to give one universal consent at the beginning of the hospital the beginning of the hospital stay for surgical or diagnostic procedures. Now it's that covers like blood draws, things like that. But if they're getting minor surgery like biopsies or extractions, suturing lacerations, diagnostic testing like bronchoscopies or cardiac catheterizations, bone marrow aspirations, anything that's invasive like that they're going to have to cut the skin for, or put down tubes for, minus the Foley catheter. We don't give consent for Foley catheters because that's a standard of care. Things like blood transfusion, thoracentesis, because those have an element of risk to them. Postmortem examinations, release of medical information, all require consent. Photos for medical use, removal against medical advice. So if you have a parent that's checking a kid out of the hospital and the doctors don't think they should go, they're going to sign forms called an AMA form, which is against medical advice. So decision making involving care of older children and adolescents, usually older than age 7 with appropriate age and maturity psychological state. It depends on how mature the children are. Should be included in the patient's assist, which is you're going to include, you don't have to have their permission necessarily, but they should be included in the discussion. It's the nurse's responsibility to assess the client's understanding of the procedure, eliciting this person of client acceptance. So that'll be a big nursing part of that, providing expectations and developing the appropriate education. So explaining to them the procedure in language that they can understand. Um, so informed consent is the same as adults with emancipated minors. So they are treated just like they are determined by law to having the same legal capacity or social status as an adult, uh, as prescribed by law. Now, there is such thing in the medical field called mature minor. Its exception to consent laws is recognized in a few states for age children 14 or older. So 14 and older may elect to consent to procedures when their parents tell them no, like blood transfusions, things like that. Um, but we may have legal action may be required for designation for the mature minor. So exceptions to these rules for consent are in an urgent medical surgical treatment to save a child's life, and a parent is not readily available or refuses to give consent. So if they refuse to give consent for life-saving treatment, um, like blood products for Jehovah Witness, then it may have to go to, like I said, an ethical board. And then there are some conditions where children are considered medically emancipated. Let's go through this. Which in some states, not all states, but for treatment for sexually transmitted infections, mental health services, substance abuse, um, and addiction, pregnancy, contraceptive advice. A lot of like Planned Parenthood and things like that don't require medical, um, don't require parent consent. Just a second. Okay. So I didn't share the first couple of screens with you. So preparing children psychologically for procedures generally decreases anxiety. It promotes cooperations with future testing, supports coping skills, and teaches them new coping skills. So don't lie to children; they're not stupid. So you want to establish the goal for nursing is to establish trust and provide support, provide explanations to their level, not using complicated words. So preparing children for a procedure, there is a good chart on page 1045 under evidence-based process. It's always good to read those evidence-based process items because that's a big push in nursing is making sure that we support everything that we do. So base teaching on the developmental age and existing knowledge allow for discussion. I know in this day and age, we're all very rushed. We want to use concrete, not abstract terms, visual aids to describe procedures. Emphasize that no other body parts are involved. Be honest about the unpleasant aspects of the procedure. Avoid words and phrases with dual meanings. Um, Clarify unfamiliar words like anesthesia. It's a different kind of sleep. That emphasize that they do under anesthesia, they shouldn't feel anything or have any pain. Stress positives of the procedure. After your tonsils are fixed, you won't have as many sore throats. When you're out of here, you'll have ice cream, things like that. Um, so as we get ready to perform the procedure, we talked about physical preparation. You have to shave a body part, make sure that they have an understanding of why. Um, Involve the child, provide distractions, allow the child to express their feelings. After post-procedure report, we want to get them to the parents as soon as they can. And that's a big part of bonding. Use play in preparing the family. Use dolls to explain the procedures. Um, Positive reinforcement, encourage, make sure you allow time. Don't have a rushed atmosphere to your care as much as possible. I know it's hard, and like I said, in this day and age, use non-threatening words or phrases, like instead of words to like shot, bee sting, stick, use words like medicine under the skin, the poke that will feel like a pinch. Um, Test, don't use the word, try to use the test. We're going to say, we're going to see how your stomach is working, or see how your lungs are working, or see how, um, ways we can make you breathe better. We'll see a picture of it, things like that. It is best to expect to approach a child as though cooperation is expected in a confident manner. Don't only give a choice when a choice is available. Um, we're going to make sure that we start discharge planning as soon as the patient is admitted to the hospital. That includes parent teaching, setting up post-procedural needs like medical care at home, equipment, things like that. Distraction is definitely a powerful coping strategy during painful procedures. And one of the most effective interventions is therapeutic play, um, which includes well-supervised activities such as permitting the child to give an injection to a doll or toy to reduce the stress. Reward systems work well, such as earning stickers or supportive care programs such as beads of courage. They can add to their necklace or bracelet certain beads that when they go through milestones through the medical treatment process. Um, if equipment is needed at home, we need to make necessary arrangements in advance so that discharge can proceed smoothly. At least one family member, but preferably two family members, will need to demonstrate the procedure they are expected to care for the child at home. Um, Let me go back to some of this is not going to be included in testing, so I'm not going to go over a huge, or it's not a huge concept, so I'm not going to list it in your syllabus. And I'm going to kind of skip through a few things of this. Uh, Looking for malignant care. Um, so post-operatively vital sign alterations in children. Children are going to be continuously monitored after procedures. Um, Heart rate may increase to maintain cardiac output, so the body compensates for any decreased perfusion or blood loss. Um, we're gonna talk about pain. We talked about using pain management scales previously. Um, so if the respiratory rate does increase, the body responds to respiratory distress by increasing the rate to try to increase perfusion. There may be the respiratory rates also increase due to fluid volume excess. So fluid volume excess is a big deal in children because they don't handle that fluid. We can't dump in a liter of fluid on a child like we do an adult and expect their body to compensate to handle that amount of fluid so quickly. If they have a decrease in respiratory rate, we need to be concerned about uh, anesthetics, opioids, pain. So a decreased respiratory rate from opioids may be compensated for by increase in depth in respirations, but a decrease in the rate. And that needs to be managed pretty quickly because we don't want them to go in, to respiratory arrest. An elevated temperature could indicate shock, which is a late sign of shock. So we want to make sure we catch it before that, or infection. Compliance strategies. Strategies that can improve compliance among interventions that encourage families to follow prescribed treatment regimens. So it's not just getting compliance from the child; it's getting compliance from the family also. For them to stick to the medication regimen that or treatment regimen that we have established is going to be most beneficial to them, like uh, using nebulizers or suctioning, dressing changes, things like that. Um, So organizational strategies involve care settings and therapeutic plan. They can involve increasing frequency of appointments to maintain compliance. Designate a primary caregiver to oversee the care. You want to have as few caregivers involved with the process as possible. Um, Reducing treatment disruption of the family lifestyle. Uh, Treatment strategies relate to the child retreatment strategies that relate to the child's refusal or inability to take the prescribed medication. So we need to have a really good uh, rapport with the family in order to recognize those cues. So we may need to change medications from pills to liquids, or we may need to put in an IV line to administer some of the medications via through the IV versus orally. Behavioral strategies um, to for compliance may include positive reinforcement is one strategy that strengthens behavior, the child earning stars or tokens, the positive feedback mechanisms. But at times, disciplinary techniques such as timeout or children withholding privileges or older children may need to be used to improve compliance, but we try other methods first. Skincare is important. Skin can break down in children fairly easy, so we want to use good oral hygiene, good bathing, maintaining healthy skin, rotating frequently if the patient is bedbound, being aware of tape, use as little tape as possible in order to keep the IVs in, which we tend to use more tape and wraps and things like that for kids to keep them from pulling out IV lines or tubes. Make sure we monitor shearing, which is just dragging the kid across the bed, and it creates shearing on the backside, on the back, and the buttocks a lot of times, which causes skin breakdown. And it's increased by the fact that they're a lot of times nutritionally compromised. We're going to watch out for pressure ulcers. Um, the pressure ulcers in children typically occur on the head, the earlobe, the sacrum, heel, scapula. So earlobes a lot of times are from if we have on nasal cannulas or if we have on a face mask for oxygen. Those are big pressure areas for children. um, so turning every 2 hours, pillows, blanket rolls, positioning devices, skin moisturizers, consulting nutritionists will help with breakdown. I wanted to go over fever, particularly. So an elevated temperature is mostly from a fever, but occasionally by hyperthermia. So there's a difference between a fever and hypothermia. So a set point is the temperature at which the body is regulated by a thermostat. The temperature's your body's temperature is regulated by the hypothalamus. So a fever is an elevation in that set point um, generally from infection. Hyperthermia is when the body temperature exceeds that set point, usually by an external condition like heat exhaustion, heat stroke, aspirin toxicity, seizures, or hyperthyroidism, being in a hot car. So there's a difference between fever to control infection and hyperthermia from an external source. Unlike a fever, just so you know, unlike a fever, antipyretics are of no value in hyperthermia. So if you give a child with hyperthermia that's been in a hot car or sometimes heat exhaustion, giving them Tylenol is not going to help bring down their fever. Um, only when it's due to some sort of infection process will Tylenol help. Um, Safety is always a huge concern for our children in any situation. So we want to make sure that in a hospital setting, we make sure that electrical equipment are out of their way, furniture, strangulation toys, preventing falls, make sure rails are up on cribs in the hospital. Infection control, we always use standard precaution and transmission-based precautions depending on what they have. If it's airborne, droplet, standard precautions, whatever type of precautions are indicated for that particular disease process, droplet, airborne, or contact, or regular standard precautions. If you don't know what they are for each, you need to review that. Page 1061. Transporting infants in restraint. Um, Infants and small children can be carried for short distances. Suitable conveyances in the hospital for more extended trips are bassinets, strollers, wagons, wheelchairs, or stretchers. Restraining methods. Okay, restraining methods are always stressful um, for family and for the child and for the nurse. So restrain the child only um, as needed for safety. When we're giving an injection, if it's we only restrain the child as little as possible as needed for safety for injection. Now that'll be important. Remember that. Any Before we restrain a child physically with or medically with medication, we want to consider diversional activity, parental participation, therapeutic holding. We want to use the least restrictive avenue in order to safely administer the treatment to the child. Examples of restraints include limb restraint, elbow restraint, vest restraint, tight tucking of the sheets to prevent movement. Positioning for procedures, mummy restraints or swaddles. Let me go back to this. Mummy restraints or swaddles are only used for the duration during the test and the procedure. It's not really considered as a restraint, like as far as the same documentation. So if we're only using the mummy restraint or swaddle for like putting in tubes for ears, things like that, we it's only for the procedure, then we don't have to document it the same as we do restraint. Um, Femoral venipuncture. So they're in the book. It's really hard to show you on the screen, but in the book on page 1065, there shows positioning for femoral venipuncture. The child is in a frog position. There is a picture of that in the book on 1065. Um, Extremity venipuncture injection. So the best place for an infant is the vastus lateralis for the IM injections. So remember that. That'll be important. So infants, vastus lateralis is the safest place for infants. Side-lying position for lumbar punctures. Um, so bone marrow aspirations, the position for that is going to depends on where they want to take the aspiration from. In children, the posterior inter-iliac crest is the most frequently positioned used, but infants less than 18 months old, the tibia may be selected. I'm not going to lecture on collections of specimens because that's the same as in adults. There's really not much change except for urine collection bag. So we don't really use urine collection bag in adults. You're going to cut, when using the urine collection bag, you're going to cut a small slit in a diaper and then pull the bag through to allow room for the urine to collect and facilitate checking on content. That's the only difference, really. A lot of times we use the urine collection bags when we're doing when infants are first born to do drug testing. Um, Another side point, we obtain stool specimens using a tongue depressor or disposable spoon or knife to collect the stool in the diaper for children. They're pretty much the same two identifiers for medication. Administering dosages. Preparing the child, we talked about a little about that before. Don't use it's going to be a poke that feels like a pinch as far as using the terminology. Acceptance of oral medications. We might want to give the child a flavored ice pop or using flavoring for medications to try to improve compliance. Avoid dairy products with administration due to risk of interference with absorption. Um, have the child pinch the nose to drink the medication through a straw. Sometimes that will help because it puts most of the taste buds are in the front of the mouth. If you use a straw, puts it in the back of the mouth. Use a nipple or a pacifier with a reservoir for the drug can be helpful also. So an infant's 11 months old and children with neurologic impairments, blowing a small puff of air in the face frequently elicits a swallow reflex. So if you have the medication in the mouth, you can blow it in their face and they will elicit a swallow reflex. On page 1077, it talks about intramuscular injection sites in children, with particularly, like I said, vastus lateralis for infants, when to use ventrogluteal and when to use the deltoid. The disadvantages for deltoid, you've probably gone over this, and is you can only use smaller amounts in the deltoid muscle. The small muscle mass is only the drug administered to children can only be 0.5 to 1 milliliter. The ventrogluteal can accommodate, and the vastus lateralis can accommodate 0.5 to 2 milliliters in a child, or up to 2 milliliters in a child and 0.5 in an infant. Sorry. I'm not going to do administration of medication. Set up the same way as in med surge, except for they have an extra safety feature where you can only, like, if something happens and it runs wide open or the pump malfunctions, it'll only get it has a reservoir where it'll only administer so much fluid. It's a safety feature. That I gotta be tested on. So sometimes we need to, intake and put of fluid. So in order to do that, we need um, to know how much a diaper weighs without fluid in it, and then how much a wet diaper would weigh with 1 milliliter of urine in it. So intake and output becomes a little more complicated when you're talking about an infant in diapers. Infants get dehydrated very quickly, infants and small children, which is why they usually set up procedures for them first thing in the morning so they don't have to be NPO as long. Um, Interosseous infusion. Let me see. Uh, I'm going to do it on this one. So interosseous infusions provides a rapid and safe life-saving alternative route for administration of fluids and medication until intravascular access is possible. So that's when a large bore needle, such as called an interosseous needle or a bone marrow aspiration needle, is inserted into the cavity of a long bone. So we don't do this that often in adults, but we do it more often in children. So there are a bunch of sites that show on page figure 39.15, page 1085 for venous access in infants. So there are a lot of sites for venous access in children. They put IVs everywhere in them because they tend to blow very quickly. So we have to have, and they're a little closer to the surface of the skin usually in infants. So they get put everywhere, um, including the head, and there are 3 spots in the head and on the legs. Rectal administration of medications. Um, you want to consider that the child's age and development, neurological status, as well as the predictability of the child. So it's an alternative route when the oral route is difficult or contraindicated. So say you don't have a line in yet, and you have a nausea medication, the child is throwing up, they're really dehydrated, and you want to to, to prevent that vomiting, and you need to administer something rectally. Um, that's an advantage. Disadvantage, it can be less reliable. They can push out the medication. It might not be absorbed evenly. Um, and it's unpleasant. Um, Pretty much the installation of medication are the same for children as they are for adults. That's generally not testable material. Aerosol therapy, like nebulizers, um, deposits medication directly into the airway. They avoid using, they are useful in avoiding systemic side effects because it goes right where you need it to. It can also be used with oxygen and then also meter dose inhalers. Meter dose inhalers are a little more tricky, trying to get children to breathe in and get the full dose of the medication. A lot of times we use spacers to accomplish that. Um, So length measurement for nasogastric or gastric gastronomy tubes is the most important aspect of the difference between, I mean, it's important for adults too, but it's really important for children. Um, Using the right length of tubing for the patient. very difficult to use age-related height-based equations for NG length predictions um, for children 8 months, for children 8 years, 4 months old or younger. They tend to, we have disadvantage of using, we can administer medications using a nasogastric tube around the clock without disturbing the child, but they tend to occlude, clog, make sure that you flush them adequately and frequently. Adults are the same way. They clog up all the time. Gavage feeding is common, especially with newborn infants. We talked about a little bit about that previously. Make sure that we don't administer, I don't know if the next slide has it, enemas. Commercial enemas can be dangerous to patients with megacolons and to dehydrated children. They can produce diarrhea, which can lead to metabolic acidosis very quickly in children. We want to really be aware of, enema administration in a child. We only use isotonic solutions in children's, which are balanced, the way they're balanced, isotonic. And when we talk about oxygen therapy, watch out of order, I'm sorry. They didn't really list all of them here, but we administer oxygen through plastic hoods of at least 7 liters per minute of flow is necessary to maintain oxygen concentrations and manage exhaled carbon dioxide. In children, also, we use nasal cannulas or prongs, depending on the age and the compliance of the child. We use CPAP systems, can provide non-invasive mechanical respiratory support for kids, but again, compliance is an issue with this also. We want to be very careful. This is important. Very careful in using oxygen in especially premature infants, because they can develop something called the retinopathy of prematurity, which can cause blindness, later on in life. So it has to do with the increased O2 levels in the blood and in the eyes. So remember that retinopathy of prematurity. Then I got to go through mechanical ventilation. We talked about enemas and ostomies. We use them the same reason we use them in adults and manage them the same way, except they're a little harder to keep on. But the skin is harder to protect in children than it is adults from breakdown. There we go. It was out of order. Plastic hood, oxy hoods for inhalation therapy for infants. I'm not going to go over end-tidal CO2 monitoring. That bronchial postular drainage, a lot of times used for chest physiotherapy. The postural drainage, chest postural drainage is contraindicated when patients have a pulmonary hemorrhage, pulmonary embolism, or end-stage renal disease. I'm not going to go through intubation, mechanical ventilation. That's really a higher specialty care that it's not going to be tested on in this test. Trachs are pretty much the same as in adults as children. Routine care requires twice a day care. Routine trach tubes are changed out weekly or after a trach has been formed. Um, Oh, talking about language development, current literature supports the use of speaking valves. So they have these valves called passing ear valves. The guy that invented it to support speaking valves to improve language development in infants and children and to improve swallowing skills and provide earlier decannulation, getting rid of it a little bit earlier. One-way speaking valves allow expiratory flow to pass through the vocal cords in order to them to the ability to speak, but a lot of times they feel like they can't breathe with them in, so it does take some getting used to in adults and children. And stop the recording and then set up the next one because we still have 36 through 38 to do before that's included on your test. So